Well, hello, everybody. My name is Benjamin Clapp. I'm a bariatric surgeon in El Paso, Texas, and I'm also an associate clinical professor at Texas Tech University in El Paso. Today, I'm very happy to be invited by Bariatric Channel to speak about a paper I wrote, and I'd like to thank the selection committee for choosing me. So without further ado, let me share my screen and start my presentation. Okay, and let me go to the front. All right, voila, here we go. So what I'm going to talk today about is the single anastomosis duodenal switch, or the single anastomosis duodenal ileal bypass with sleeve in the United States. And this is a paper I wrote with my friend and partner, Omar Ghanem, and we use the MBSAQIP database to do so. Now, my disclosures are travel and food from Medtronic and a food stipend from Ethicon. None of those will have any bearing on what I talk about today. My objectives today are to familiarize the audience with the MBSAQIP database and to compare the safety profile of the SADI to the Roux-en-Y gastric bypass, the sleeve gastrectomy, and the biliopancreatic diversion duodenal switch. Now, I'm going to refer to this as the SADI from here on out. I mean, the SADI is kind of a mouthful. It's a relatively new procedure, but it's a variation of an older procedure, the biliopancreatic diversion duodenal switch. And it was popularized in Spain as well as now in the United States. It's becoming more and more of an option for us in the United States. In fact, it was endorsed by the American Society of Metabolic and Bariatric Surgeons in 2020. Now, that was a key for us because that endorsement allows a couple of things. It allows us to collect data in our national registry, the MBSAQIP, and it starts us down the path to insurance companies accepting and paying for this procedure, which is a big thing in the United States. People can pay cash for these operations, but when it's paid for by the insurance, the adoption rates will go very high with this. Aetna and Cigna are two of the big insurers in the United States, and they're now covering it, as are some Blue Cross Blue Shield policies. So again, this is the first step in widespread adoption in the United States. Now, for those of you that are not from the United States, the Metabolic and Bariatric Surgery Accreditation Quality Improvement Program was sort of a game changer for us. What this did is this is run by the American College of Surgeons and the ASMBS. It's a joint venture, and it allows us to become accredited centers. In fact, there's over 900 centers now in the United States that are accredited. We get reaccredited every 2 years with a side inspection, and we've collected data on over 1 million patients at this point. This went online in 2015. We collect over 200 data points for each patient that is de-identified, so it's HIPAA compliant, privacy compliant, and we collect 30-day outcomes. And that's one of the weaknesses of this database, is that we don't collect more than 30-day outcomes. Now, for an accredited center to continue to participate, they have to have at least 80% follow-up in that month, or we drop their data out of the database. So we think this is good data. We do internal validity checks on this data, and the database itself, as it's maintained, is constantly evaluated. So when we look at this and we look at our data from 2020, we see that we first started to report the SADI at this point. Now, these were small numbers. There were only 488 out of the 168,000, which was 0.3% of cases. And this did include revisions at this point. When we go to 2021, we see that the numbers doubled to 842, but we see that sleeve continues its dominance with 60% of all the cases. But I think what we need to point out here is revisions as well as the SADI. And here you can see highlighted that revisions are the third largest category of cases that we do in the United States, 25,000. And when we think about the SADI, a lot of us that are starting to adopt the SADI see it as a good revision for sleeve gastrectomies. We know that the biggest percentage of revisions are sleeves. Of that 25,000, they're sleeves. And we know that the bypass, or we think we know that the bypass, Roux-en-Y gastric bypass, is probably a better operation for reflux after a sleeve. But what is the best operation for weight gain after a sleeve gastrectomy? Well, bypass will work for that, and you'll lose about 40% of your extra body weight. But we know that the SADI and the BPD-DS will do a little bit better than that. And I think that's where we're really going to see the growth of the SADI. So how does it compare in 30-day outcomes to the other operations? Well, this is the paper that we wrote. Single anastomosis duodenal ileal bypass with sleeve in the United States, a first comparative study, safety analysis of the Metabolic and Bariatric Surgery Accreditation Quality Improvement Program Database. I was the first author, and Omar was, my friend, was the senior author. John Corbett is now an intern in Washington State, or Washington, D.C., and Monica's a chief, and Ray's a research fellow, and they're all moving on up to bigger and better things. If we look at the study design, by nature, any study on the MBSAQIP is going to be retrospective. And since we had such small numbers for these first year of the reported data, we wanted to do a propensity match analysis to compare the outcomes. So we used a 5-to-1 matching analysis for the room-wide gastric bypass and the sleeve gastrectomy, just because we have more numbers for that. And we have less numbers for the BPD-DS, only 3,000 reported a year. So we did a 2-to-1 propensity match analysis. Now, these patients were matched with 20 different variables, and we did exclude revisions. So here we can see, as we filtered out the revisions, we dropped down to 91,000 and other cases. That drops us from the 488 to 255 for the SADI because of the fact that we had to drop revisions out. But we had 24,000 bypasses, 782 switches, and 66,000 sleeves, giving us the numbers that you see there on the bottom. Now, when we look at the goodness of fit with matching, we see that before matching, we're pretty wide there with the bypass. After matching, we have a great fit. Same thing with the sleeve gastrectomy, and same thing with the duodenal switch. When we look at patient characteristics for pre-matched versus post-match, we see that after the matching, which is the last 3 columns over here, that we essentially have a very tight fit with matching as far as patient characteristics, age, BMI, and comorbidities. Now, this table, it was just table 2 in the paper, is actually kind of where the money is. And again, if you're a young surgeon and you're starting to get used to reading the surgical literature, when you look at the tables and graphs and figures in a article, that essentially is the story of the article. So this table is the 30-day outcomes for SADI versus the room-wide gastric bypass, BPD-DS switch, and sleeve gastrectomy. Now, here you can see the operative times are a little longer for the SADI. The only thing longer was the switch. And for the room-wide gastric bypass, the sleeve gastrectomy, it's much longer. Length of stay is roughly the same. It's about 1.6 to 2 days. Not really sure what the difference in between a 1.2 and 1.6 day stay is. I know what is in hours, but I'm not sure that clinically is significant. We did something different in this paper where the database reports individual complications: urinary tract infection, sepsis, infection, leak, bleeding. What we did is we used the Clavien-Dindo classification. It makes it a little more easier to digest. If you have 40 different complication outcomes, how do we get that down to where we can look at that and have it be a clinically relevant thing? And the Clavien-Dindo classification, I think, is the best way to do that. And we do include a table, a supplemental table in our paper that shows what we chose as grade 1, grade 2, grade 3A, 3B. We use the standard definitions, though. So, and we also looked at readmission, reoperation in this table. So if we look at just the complications and we compare them by a procedure, so if we take the SADI versus the gastric bypass, we see that there's grade 4A and 4B complications are greater at 1.6 versus 7.1% and 0.1 to 1.4%. And these are statistically significant. If we look at the SADI versus the sleeve gastrectomy, we see higher rates of complications in grade 2, 4A, and 4B. Again, all statistically significant, 1.3 to 3.5, 0.2 to 1.6, and 1 versus 7.1. And so it's a little more more complications with the bypass and the sleeve. But when we compare it to the DS, we find only grade 2 complications are found to be about 4 times higher, and again, statistically significant. So when we looked at readmission, reoperations, and reinterventions by procedure, we see the SADI versus the bypass, that the only thing that really stands out is reoperation rates are a little bit higher, 3 times higher, actually, and that is statistically significant. When we look at the SADI versus the switch, we see that everything's pretty much equal. There's no statistical difference in between the two. And we look at outcomes of readmission, reoperation, reinterventions with the SADI versus the sleeve gastrectomy. Again, we see that there is a higher reoperation rate, again, it's much higher, actually, which was, again, not unexpected when we look at overall complication rates. So taking our discussion, move my picture back over there, the SADI is a very safe operation. It's got very low rates of complications. Although it is higher than the bypass, the sleeve, those are still very low rates when we look at those. So it's got a very low risk of reoperation, readmission, and reintervention, but it is greater than the sleeve gastrectomy and the Roux-en-Y. But it's early in its adoption curve. And our growth of the SADI will likely be high, especially with the amount of revisions that we're going to be performing on sleeve gastrectomies. Most people are estimating somewhere around 30 to 35% of sleeves will be revised. And what are we going to revise them to? Limitations of this study? Well, it's a large database. It loses its granularity. So we don't know if these were performed in high volume centers. We don't know if these were surgeons that were expert and passed their learning curve, or if we're seeing the learning curve. And we're limited by 30-day outcomes. Obviously there's complications and things that occur after 30 days, but we're seeing the operative safety here. And we may be missing cases. There's not really a CPT code. And if these cases are performed in an ambulatory surgery center, we may be missing a significant number of cases. I personally know surgeons that have done 2,000 of these, and they're not done at an accredited center, because with an ambulatory surgery center, there's a little difference in getting their accreditation. It costs money, and there may not be a driving force to become an accredited center. So our conclusions: the SADI has higher complications and reoperations than the sleeve gastrectomy and the bypass, Roux-en-Y gastric bypass, but it has equivalent outcomes to the switch. The SADI will likely become much safer as more experience will be gained, and we'll see the widespread, I think we'll see a widespread use of the SADI throughout the country. That's all I have today. Thank you again for the invitation, and I'll be happy to answer any questions in the question and answer period.